Hey there, everyone. Welcome. Thank you so very much for being here with us for ACFCS's Anti-Human Trafficking Spotlight series. I like to affectionately call the Metcalf series with Kevin Metcalf. Each month, we like to, for the community, free to the community, we like to spotlight different subtopics inside the anti-human trafficking industry. And with that, I will introduce you to Kevin and the awesome, amazing Francine that he has brought on this month to talk about healthcare fraud, the hidden in plain sight, human trafficking, healthcare fraud, and the financial clues that connect them. We're going to talk about this in length. We're going to have 90 minutes today to discuss how you in the financial crime compliance space can see these breadcrumbs that are left, can see these people that are suffering, and can help stop it. And with that, we're going to have to do the boring stuff, as you know, the troubleshooting, as always. This is a web-based platform on On24. If you're having any audio or video issues, just go up to your URL, refresh your browser, and then come right back in, rejoin. Make sure you're on Chrome or Firefox. That's definitely going to be your best bet on this one. And even if that doesn't work, try an incognito window. That sometimes helps. Your closed captioning is on the lower right-hand or left-hand corner, depending on what you're looking at, of your media player. Your media player is where you see the three of us right now. Go ahead and click that white button, and it has CC on it, and your closed captioning should start right there. Your certificates of completion, I know that it says attendees for ACFCS members. I think everyone's going to get their certificate today. Your certificate of completion is set to, if you watch 80% of it, so don't worry about that part of the slide that you see up there. You will get your certificate of completion. Recording and slides. The slide deck is in a PDF format in your resources box. Wherever you've got your resources box on your dashboard, you'll see the slide deck. If you don't see it right now, scroll down. You'll see it. And you can go ahead and download it and follow along if you'd like. The post-webinar survey is on there. Let us know what you'd like to see, what you want to see more of, what you would like to know about us from a perspective of ACFCS. Q&A. Now, Q&A is one of the most important things. There's a lot of people on here that may or may not be members of ACFCS. So if your Q&A, you have a question for the speakers, go ahead and submit your question in the Q&A box. You'll see it kind of disappear. Don't worry, we have it on our end. And that makes sure that you're in line to be able to get your question asked. There's also an attendee chat button box here, and I can see you guys are using it already because there's a lot of folks on here that are members, and we always like to ask our folks, where are you logging in from? All right, Texas, I see you, Kelly. Thank you for being here from Texas. We got Texas going on right here. Also, speaking of Texas, there's kind of a bit of a downpour right now. There's thunder and lightning, and if I lose my connection, I will have a colleague come in and step in. But if you see one of my colleagues come in at the end of the presentation, that means I've lost my connection due to a big thunderstorm. So thank you for your patience on that one. We've got Bermuda, Massachusetts, Florida, lots of different places going on. Indianapolis, Alberta. We have a very big Canadian presence and membership in our community, so we're really grateful to our Canadian neighbors up north. We've got, I can't even see, South Florida, Toronto. Thank you so much for letting us know Ohio, where you're logging in from. That's always fun to see where you are geographically. Again, if you want to talk with your folks here about anything, networking, appropriate types of comments for the content, go ahead and throw them in there. Network with your folks here in the attendee chat. We love seeing that. Your Q&A should stay in the Q&A box so that we can see the important questions that you want to ask us and that we can get to them. So if you put them in the attendee chat, the chat goes so much. There's so many of you now on this. We had almost 600 people sign up. We don't want to miss it. That's why it's really important for the Q&A to go in the Q&A box if you have a question. All right, with that, I think I've done that one to death. I also need to let folks know, there's a lot of folks on here that are not members. So just want to let you know, I put in the resources box links to what's coming up for ACFCS, what we already have rolled out. We have a Detecting and Understanding Human Trafficking certificate course. Go ahead and click on that, and it goes right to the website, and it has as much information as you would like on that particular certificate course. This course was put together by myself, my colleague Cheyenne, and a survivor. Her name is Holly Nadell. She has a collaborator's comment in the front of the course itself, and she provided us with a ton of information on what she learned as a survivor when she was actually going through her abuse. And her life's work is now to educate the financial crime compliance community because she was saved by a bank teller. Let that sink in. She was saved by a teller who had the intuition enough to pull her away from her trafficker with her manager and sat her down and said, I see you. If you are in any problems, any trouble, let me know. That means, hey, guess what? What we do matters. from the front line to the back end where we are looking at these transactions, as well as what Francine will talk about, the healthcare part of it. You see these survivors in what you do, and you see these victims, and you are able to help them. And that's why we're here today. Also, if you purchase the Detecting and Understanding Human Trafficking course, 10% of the proceeds goes directly to Holly. And that is a wonderful thing that my company has decided to do. And also, if you decide to get membership today, you can bundle starting December 1st, excuse me, starting December 1st, pardon me, you can bundle. We have the option of bundling a 1-year membership with the Detecting and Understanding Human Trafficking course, the certificate, for 10% off as well. So 10% would go to Holly, 10% goes to you for bundling, and then you have a year membership. It's a really, really good deal starting December 1st. Okay, with that boring stuff, I'm going to go ahead and start our poll while I hand it over to our speakers, especially for Kevin. What's the biggest challenge your institution faces in detecting potential trafficking tied to healthcare fraud? Lack of data or typologies, difficulty identifying beneficial owners or shell entities, limited staff training. If anyone does see, write to me. I'll put my email address in the attendee chat. Fragmented reporting across departments or other. Tell us in the chat what the other is for you. I'd love to see it. And while our folks are answering the poll question, Kevin, tell us about yourself.
Thank you, Erin. That's a lot, and you reminded me of a few things. One of those being that we are doing a little better at getting the word out. I know that in every field, of course, I've worked in the military, law enforcement, those two, while they're getting better historically, they have not considered things like therapy or weakness or any other issues. So if you're new to this sort of discussion, be aware of your own reactions, especially if you have some trauma in the past. This can trigger just things that you wouldn't expect. If you're just now exposing yourself to this, make sure you take care of yourself. Don't hesitate to turn this off. Find somebody to talk to, but I really wanted to make sure I remember to put that out this time, because I have a lot of people when they'll come to a talk, and for me, I have dealt with trauma or just nasty parts of life for 30, almost 40 years, and I don't think of things. So be sure to take care of yourself, because if you can't take care of yourself, you're not taking care of anybody else. So just remember that it's not weakness, absolutely not weakness. So make sure that you're monitoring yourself as we go through this. And if you're new to this, this is a big factor. So my name is Kevin Metcalf. I have spent, as I already said, almost 40 years, 30, I think I counted up the other day, 37 years in military, state, local, federal law enforcement. I spent a little over 12 years as a prosecuting attorney, founded the National Child Protection Task Force, and was a founding member of Raven. So I've been involved in a lot of different aspects of just how inhumane humans can be to each other in so many ways. When I got into the human trafficking element, it was sort of accidental. I found out I was really good at technology and figuring out how to track people and identify them. And as I was doing that, working the more exciting drug cases or working the terrorism cases, I really got to see how the most vulnerable among us are targeted and groomed and exploited and used. And then when you really start getting into it, I was coming at it from a law enforcement view, and I figured out pretty quick, there's only so much I can do. And when I get involved, things have already been really bad, probably for a long time for people. So when you look at the human trafficking and the exploitation side of things, this is going to take an ecosystem. And last year I was setting up that ecosystem in Oklahoma. And as I was developing and looking at it, I realized I need financial. That's Erin and ACFCS coming in to do the training for it. We had transportation and energy. So luckily TAT was available, Truckers Against Trafficking. Healthcare is a major touch point for a variety of things. And when we say human trafficking, Fran's going to get into some areas that don't normally come to mind for us when we think of trafficking. Most people think of sex trafficking, and it's because it's got sex in the title. But there are other things that touch healthcare, and when you really start looking at it, it spider webs out into finance, which is one of the bigger reasons we're here today. And a lot of us here have children in our lives that we care about. So as we're going through this today, as Fran talks, keep in mind that there are runaways or foster kids, or, well, let's just call it what they call it out in the real world, throwaway kids. These are kids that society has determined are not really worth our attention. So those kids are just out there, and they're identified by predators, they're identified by traffickers and people who will just take advantage of them. So remember, there's that, but there's also that group of kids that Fran will address at some point here, that have parents or adults in their lives that care about them, that also fall into traps, and that can also possibly be identified in the healthcare setting. So just want to lay this out there, that if you're new to this type of discussion, human trafficking is not simple. It is extremely complex. Right now, I'm working with prosecutors and defense attorneys who say, I know what trafficking is, I know what it looks like, and I'm saying, it's right in front of you. Here she is, that's her, this is her story. And they say, that doesn't look like trafficking. So don't feel bad if some of this stuff is going to be new to you. Just open your mind up, make sure that you take in everything that we're getting into today. So I've rambled on enough, but that's kind of my background. And at this point, I am fortunate in knowing some incredible people in various sectors. You're looking at two of them today, Aaron and Fran. And when you put those two together, they magnify everything exponentially, any topic you get into. And then when we add more of these experts coming in, it's just amazing that the power that's here and the collaboration. Aaron, did you want Fran to go ahead and introduce herself, or do you want to go over the survey? All right, so
introduce yourself.
I would like to hand this over to Fran, but I've got to say she has, I don't remember when I met you, it's been years, but she has become a very close friend of mine. And I think, as Aaron can attest, that she becomes a very close friend of everybody. So it's really wonderful to have this circle. But Fran, if you would, tell us about yourself.
Yes, of course. And thank you so much for that, Kevin. And likewise, Aaron. So I am a proud member of the nursing profession now for 33 years, seasoned healthcare professional, registered professional nurse, pediatric nurse practitioner, trained sexual assault nurse examiner at this point, academic nurse educator, and I am the co-founder and president of Nurses United Against Human Trafficking. And some of my story I will actually get into during the presentation. I think it is just a little bit more profound that way, how I entered the anti-trafficking space and how personal this is to me. But Kevin, thank you so much for really providing the foundation and the groundwork for this. This is something that is impacting all levels, all facets of society, daily living. Again, human trafficking is this umbrella term, but there are so many different forms of the crime that fall under this term. And so it's not always going to be how the media is depicting it or how Hollywood films are depicting it. And as much as I appreciate these different outlets really putting human trafficking on our radar and making it such a buzzword, unfortunately, they are perpetuating these stereotypes and these myths that really do not reflect and depict what human trafficking looks like here domestically. So with that, thank you all for being here. And again, Aaron and Kevin, love you both, such dear colleagues and friends of mine, and just truly a wonderful opportunity to shed some light on the intersection of human trafficking, healthcare, and fin crime and compliance. So thank you so much.
Thank you, Francine. That's awesome. You guys, I got chills. You're awesome. All right, we got 45% of our attendees who have answered it. We're going to go ahead and look at the poll question. We have the lack of data or typologies is at 34.4%. I couldn't agree more. Difficulty identifying beneficial owners or shell entities. Yes, 16% have said that one. That is a tough one in these financial crime investigations. Oh, you have to go down a rabbit hole for beneficial owner. It can get completely onerous. Limited staff training. 23% of you need to be writing me. I want to get some emails. I put my email out there. Let's talk. Fragmented reporting across departments. That's another big one. Obviously, we have fraud and we have AML that can be siloed. We have a lot of other different silos inside our financial institutions, which need to be broken down as much as they can be. And others, and you guys have been writing in the chat about lack of customer interface. I saw that one. A recording is going to be provided, Miranda. It's going to go up on YouTube. This entire webinar is going to go in its entirety up on YouTube on our channel. So go ahead, you can watch it there. If you're a member, you can also watch it on your member portal. So 2 different places. So thanks for that good question. Also, fragmented data across systems. That's a really good one. And lack of training, and this is going to be the ushering in, Francine, lack of training across healthcare staff is what someone wrote here in the chat. And so we're going to get into that. And with that, I'm going to shut my mouth and let Francine take it away. And I'm going to turn off my camera.
Perfect. Thank you so much. So just a disclosure statement, neither Kevin nor I have anything to disclose, and there are no conflicts of interest that exist. And Kevin, kudos to you. Thank you for that trigger warning. I always do include a trigger warning in my presentations. Please, if at any point something is making you feel uncomfortable, the content that we are sharing, this will specifically speak on uncomfortable and sensitive topics. Please, if at any point you feel the need to take a break, walk away, please feel free to do so. Again, this is something that is very dark, very uncomfortable, lots of sensitive information that we will be discussing in terms of the content. And so please, if at any time you need to take a break, please feel free to do so. I am also happy to answer any questions, not only during this session, but if anyone would like to have a private conversation afterwards, I'm very happy to do that. My email is info, I-N-F-O, @nuaht.org. I'm happy to engage in a conversation privately. So just some learning objectives. We are going to identify the significant intersection of human trafficking with healthcare, as these victims are coming in for diverse acute care needs, chronic healthcare concerns, mental health concerns, comorbidities, lots of different healthcare concerns, and that is what is bringing them into the healthcare sector for treatment. We're going to recognize the significant lack of healthcare professionals' preparedness in knowing how to identify and how to appropriately treat this population. There is a different standard of care for this most vulnerable population, and healthcare professionals are not being educated on how to do so. We are going to discuss human trafficking, misconduct, and fraud within healthcare, and the intersection points with ramifications, again, in the financial sector. So please understand that there are more slaves today than ever before in history. We had the Emancipation Proclamation, the 13th Amendment. You know, slavery was supposed to be abolished, but human trafficking is a form of modern day slavery in which individuals are truly robbed of their freedoms, of their rights. And this is something that is being seen throughout the world. And again, please understand that it is happening domestically at exponential rates. When we look at the financial gain, let me step back for a minute and put this out there. Unlike an illicit drug or arms deal, once that product is gone, inhaled, injected, if it's a drug, or that gun is sold, traded, whatever it is, that seller can no longer profit off of that item. But a human being can be sold over and over again. And this is where they are coming in, intersecting with us as healthcare professionals. But when we look, for some reason, my slide advanced. Oops, I don't know what happened. Okay, so here it says estimated annual global profits is $150 billion. Please understand that these are based on older metrics. NASDAQ and Verifin in 2024, and if this is your niche, I'm sure that a lot of you are familiar with this report. It was, I want to say it was published in March or April of last year. They are estimating that human trafficking grosses on an annual basis globally approximately $350 billion a year. This is all tax-free money off of the sale of a human product. And you know, when we look at that number, that is pretty significant in and of itself. But just to frame it a little bit differently, it is approximately equivalent to Nike, Google, and Starbucks combined. It is a financially motivated crime. There is no doubt about it. And please understand that it is not a standalone criminal enterprise. We have, again, drug trafficking. We have the illicit arms trade. We have terrorism, cryptocurrency. All of these pieces, or all of these really these criminal enterprises, they are all fueling and financing each other. So these are not standalone criminal enterprises. They have broken down the silos. These perpetrators understand that there is significant financial gain breaking down these silos. Unfortunately, we went as professionals, depending on our discipline where we are coming from, we still tend to be siloed, and we need to break down those silos and understand. And just as Erin and Kevin really set the stage for this this presentation, we need to work together collaboratively, sharing data, sharing information, and recognize that when we all come together, having a seat at the table, we can tackle this multifaceted problem with a multifaceted approach. So when we look at human trafficking and healthcare, 70 to 90% of trafficking survivors accessed healthcare at some point during their exploitation, with the majority of them being missed, nor were they offered resources. There are two truly historical studies that have looked at this population retrospectively as survivors, asking several questions, but one in particular was, did they ever access healthcare, or were they seen by a healthcare professional at some point during their exploitation? And please note again, 70 to 90% reported, yes, I was seen by a healthcare professional, with the majority of them not being identified nor offered resources. So the intersection of human trafficking with healthcare, again, is exponential. When we look at healthcare professionals' preparedness, there have been studies that were conducted looking at licensed healthcare professionals and their knowledge of human trafficking, their level of confidence in knowing how to identify a potential victim, how to appropriately respond. It is not happening. Historically, though, we are seeing somewhat of a trend showing that these numbers are improving. But there was a systematic review that was published in 2022 that showed that approximately 90% are still reporting that they are not educated on this topic. They don't know how to identify. There is no formal education. And so we truly are failing as healthcare professionals in identifying this population. And so I just would like to share my particular story and how I entered the anti-trafficking space. So again, being a seasoned healthcare professional now for 33 years, over 33 years at this point, I have worked as a registered professional nurse, pediatric nurse practitioner, predominantly pediatric intensive care, the acute care setting, working with the pediatric population. And once I transitioned into academia, I became an academic nurse educator, clinical instructor, as well as didactic professor. And so in the fall of 2018, I was bringing in my group of students. At the time, I was living in New York. I know my accent is still very thick, but I do live in Florida now since 2021. But at the time, I was in a very affluent area of Long Island, New York, and I was bringing my clinical students in, pre-licensure nursing students, who needed that pediatric rotation component to complement their pediatric didactic course. And so we were at a level 1 trauma center teaching hospital, and we were up on the pediatric floor. We received a call from the emergency department saying that there was a 16-year-old who needed to be admitted, very significant cellulitis to the left arm. Cellulitis, for those of you who may not be familiar, is a skin infection. And so she needed to be admitted, requiring IV antibiotic therapy, hydration therapy. And so I had assigned one of my students to shadow the nurse who was taking the admission. There were some other students who weren't busy, and I'm a very hands-on clinical instructor. And so I walked into the room with my students to help with the admission process. We walked in. I still to this day get the chills thinking about this 16-year-old female. She was in such a bad way. She had lice. She was covered in IV drug marks, very poor hygiene, including dental. She had numerous skin infections. The cellulitis that she was being admitted for was borderline septic. I mean, it was so profound. And now in this space, I recognize that treatment was delayed. History of sexually transmitted infections, UTIs, which is urinary tract infection. Her urine was positive for polysubstances, illicit substances. And I'm thinking, she's 16. How does this happen? At the time, there was an older gentleman who was sitting in the visitor's chair. He was twice her age, the complete opposite of how she presented. He was well-dressed, well-spoken, clean-cut. And I'm thinking to myself, how does he know her? Like, who is this person to her? And so very professionally, I went over to him. I introduced myself. I said, please, if you could just tell us the nature of your relationship, who you are to her. We're taking the admission history. And he said, yeah, of course. He said, she's just a very good friend, and I'm worried about her, and I want to take care of her and make sure that she's okay. And I'm thinking to myself, how are you doing that? I mean, she is in such a bad state. But of course, I was very professional. I call it my poker face, you know. And I thanked him for providing the information. And I knew something was wrong. I didn't know what it was. So fast forward to the following year, it was June of 2019. At the time, I was serving on the board of directors for the American Nurses Association for the state of New York. And I was in Washington, D.C. for Membership Assembly National, as one of the board members of a state constituent of ANA National. And so there were probably over 2,000 of us at Membership Assembly, and who is now my colleague and co-founder, Tammy Tony Butler. She actually was selected to present at Membership Assembly for ANA for that year, and she's presenting on human trafficking. And she's going into the signs and symptoms, the clinical presentations, how they are going to access care, what it's going to look like. And I'm thinking, no, this is not possible. I mean, at the time, I was already a registered nurse, pediatric nurse practitioner for like over 25 years. And I'm thinking, how is this possible? It was as though she did a case study on this 16-year-old. Not only did I fail as a mandated reporter of that 16-year-old, every single one of us at that facility did. She was brought into the ER. She was seen by the attending, the residents, the nurses, brought up to the floor, seen by the attending, the residents, the nurses, me, my students. Not a single one of us knew. And I'm thinking to myself, how many others have I failed? How many others have all of us as healthcare professionals failed? And so very fortuitously, I ended up running into Tammy in the lobby after her presentation. And I said, please, I need to speak to you because I was hit by an 18-wheeler during your presentation. And so I started to share the details with her that I shared with all of you. And she looked at me so matter-of-factly, and she said she absolutely was being trafficked, and her trafficker was sitting right there. I handed her my business card. I said, I don't know how to help you, but please let me help you. And that literally was the birth of Nurses United Against Human Trafficking. There was this fire that was lit inside of me that I swore I would do everything in my power to not have another individual who is being exploited be failed by another healthcare professional. So Tammy and I started working together, and, just going back to the preparedness of healthcare professionals, these studies that were conducted were of licensed healthcare professionals. And being in academia, specifically working with pre-licensure nursing students, I'm thinking to myself, well, what is the current landscape right now? What are we teaching? Are we teaching on human trafficking at all in that pre-licensure nursing program? And so I would speak to some of my colleagues in academia and say, listen, are you teaching on human trafficking? And some of them would actually respond, yes. And I'd say, wow, that's wonderful. What are you teaching? And they said, oh, we put like a slide or two in one lesson. And I'm thinking, okay, so we not really are teaching on human trafficking. And so Tammy and I said, you know what, we really need to take a deeper dive and explore what is happening at that pre-licensure nursing level, because as RNs, we not only comprise the largest portion of healthcare professionals in this country, but globally. We literally work in all facets along the healthcare continuum. We are an army waiting to be deployed. But without this knowledge, we are going into this battle defenseless. And again, working in all facets of healthcare, we are ideally placed that we can, with this knowledge, be able to promptly identify, appropriately respond, and report as mandatory reporters, as mandated reporters for those that are meeting those mandatory reporting guidelines. So Tammy and I did a study nationwide looking at pre-licensure RN programs and what was being taught and their level of knowledge. And so we were able to, teaser there, sorry. We were able to gain access to the National Student Nurses Association, which is a professional association comprised of nursing students in this country. We specifically had in our inclusion criteria that they were NSNA members, that they were RN students, and that included diploma, associate degree, as well as baccalaureate degree. Or we also included those that had graduated within a year of our survey going out, because we figured that they would still have some recollection. So after the data were obtained and cleaned, we had a total number of 644 respondents, representation and distribution literally from across the country. We were only missing from Maine, Wyoming, and DC, if you could imagine. I'm just going to say that was a technical glitch. But one of the questions we asked was, okay, so how much are you being taught? How many minutes are you being taught human trafficking content? And you can see that over 91% reported minimal to 0 minutes being taught human trafficking content. Now, please recognize that a majority of our respondents were fourth-year pre-licensure baccalaureate students. So we were not capturing them in first-year growth and development or, nursing professionalism or anything like that. They were pretty much at that point near completion of graduating. And we also had a good portion of our respondents as already graduated licensed practicing RNs who were responding. One of the other questions we asked, we did a perceived human trafficking knowledge sum score. Almost 82% reported some to no knowledge on human trafficking. We had two outcome variables that we were looking to explore. One was their level of confidence in knowing how to identify a victim of human trafficking in the healthcare setting. Less than 1% reported full confidence, with approximately 3/4 saying, I'm only halfway there, if at all. And we had used a visual analog scale, with 0 being no confidence and 100 being full confidence. The other outcome variable that we looked to explore was their level of confidence in knowing how to appropriately respond and treat this population of victims in the clinical setting. Less than 5% reported full confidence, with again approximately 3/4 saying, I'm only halfway there, if at all. And so as healthcare professionals, with the retrospective studies showing 70 to 90% of survivors said, yes, I was seen by a healthcare professional. And again, with the lack of knowledge that is being taught pre-licensure, we are seeing them, but they are literally invisible to us. What are some of the identification barriers? So diagnostic overshadowing, what does that mean? That means that once a client comes in and a diagnosis is made, everything that this client is presenting with, the chief complaints, other physical findings, subjective, objective data, we are just putting it under this umbrella of, yes, this is what it's referring back to. Perfect example, someone comes in reporting that they were standing 1 minute, the next minute that they are waking up and they are on the floor. Now that sounds like a syncopal episode, meaning a fainting episode, but are we recognizing that that could also be a non-fatal strangulation? So again, we are missing a lot of the signs and symptoms, red flag indicators, because we are not being properly educated. And when we look at the education, the study was conducted. We know that pre-licensure RN students are not getting this content. So once they graduate and become licensed RNs, it falls on state mandates. Approximately, and this is loosely, only 15 states currently have in statute that continuing education is required for nursing and for healthcare professionals in general. So if healthcare professionals are not licensed in a state that has these rules, these laws in statute, healthcare professionals are not getting it at all. You know, we have our own preconceived notions, biases. We have these frequent flyers, which I hate that term, but I think everyone here understands what that means. It's like that super utilizer. You know, we have John who keeps coming in as a near overdose. Is anyone stopping to say, hey, John, what is going on? What is happening with this man? Or are we just saying he's just strung out on drugs, some throwaway youth, that Kevin had used that term? Are we going beneath the surface of what this gentleman is presenting with to say what is happening here? Or are we just putting our stereotypes? Those that are the missing, endangered, runaway youth, right? That are couch surfing, that are with unstable housing or homeless. Is anyone stopping to say, hey, what are you running from? There could be abuse within the home. 40 to 50% of children who were sex trafficked, they are being trafficked by a loved one, mother, father, grandparent, aunt, uncle, older sibling. That's called familial sex trafficking. And we cannot conceive of this, but this is the reality. Parents need to fuel their addictions. They need to keep a house, a roof over their heads, or, you know, pay the electric bill. By no means am I condoning this. Please don't misunderstand me, but this is what's happening. are we seeing Billy, who's coming in as that 10-year-old boy who is complaining of chronic bellyache, that we are saying, well, Billy just doesn't want to go to school today, or Billy just doesn't want to take his test today. You know, they're coming in with these somatic complaints, and we have the stepmom or the biological father who's bringing him in. Billy, that 10-year-old boy, could be the victim, and that stepmother or father can be the trafficker. And so again, there are a lot of stereotypes that it's only a female victim with a domineering older male trafficker. No, we need to understand that victims can be any race, age, sex, gender, and likewise the trafficker. You know, we have these isolated, stigmatized populations. We are overworked. The patient to nurse ratio, or patient to healthcare professional ratio, truly is high. There's lack of knowledge, again, and we covered that. Lack of policies and protocols. Are we screening? These are all some of the identification barriers. So just to go over a couple of red flag indicators. So we have lack of eye contact. They can be demure. They can have a flat affect. However, we can also have them presenting on the other end of the spectrum or continuum, where they are combative, they are aggressive, they are in your face, they are detoxing, perhaps they're not maintaining modesty. And so some of these 1 and 2 hour trainings, that as much as I appreciate the ones that are out there, you know, they're depicting this group of victims as very demure, tremulous, anxious, but we can have them completely on the other end of the spectrum. And so we need to understand that they can present in a wide variety of ways when it comes to their behavior and affect. Fear of law enforcement, fear of speaking about their living arrangements, their work environment. There's transient living, movement from city to city. Now, please understand that transportation is not necessary to be considered trafficking, but there is a lot of transient living and movement, interstates, along the interstates, those who are on the corridor of I-95. I mean, here in Florida, we have I-10, I-75, 295. There's 495, you know, so please not 495 here in Florida, but just those of you who are living in states with those major thoroughfares and those that are connecting, those are very big hubs. And again, it's not always sex trafficking. There's labor trafficking, those states or areas where there is a lot of agricultural work, crabbing industry, manufacturing industry. So again, you know, not to just focus necessarily on sex trafficking. These individuals, when they are coming into the healthcare setting, they are not in possession of their ID, their birth certificates. And of course, this is developmentally appropriate, but please understand that is another form of control. I've actually had survivors, and when I use the term survivor, you know, it's someone who was exploited, who is a lived experience expert. Even when I use the term victim, it is a term that is readily acceptable. It is a law enforcement term, but by no means do I want to depict this individual as someone who is hopeless. This damsel in distress is another way of identifying with the term victim. It is someone who is being exploited by a perpetrator who is actively under this person's influence, or who is actively being exploited. So please understand, when I use the victim, that is the way that I intend it. So one of the survivors that I actually work with for years, she's a very dear friend of mine. She's actually reported that she had a choice, and I'm putting that in air quotes, to either provide commercial sex to sex buyers, or she was able to have the choice of buying merchandise using stolen credit cards. She ended up being arrested for that. So there is forced criminality. I mean, with the vacateur laws, she actually was able to have those charges expunged. But please recognize, again, there are a lot of different forms of trafficking that fall under this umbrella term of human trafficking. But again, not in possession of their government issued ID, birth certificate, etc. History of truancy, running away, again, those missing endangered youth. School nurses, are we seeing these individuals, and again, having our preconceived notions and saying, oh, just Sally doesn't want to go to school today. She's, back in the nurse's office with a headache. Unexpected cash gifts, expensive clothing, etc. When we look at human trafficking, and it really since COVID, we had academic progression online, work was progressing online, and I'm talking to the masses of all of us. We've pretty much stayed there, and traffickers recognize that there are no more geographical boundaries. They have access to an infinite number of individuals that they can manipulate, and these individuals can fall prey to trafficking. And so not only are we professionals within our respective discipline, but we're parents, we're aunts and uncles, we're grandparents. Are we seeing our children or our loved ones that are on Minecraft, Roblox, Fortnite, Call of Duty, social media? Are we thinking that our loved ones are safe because we've locked our doors and locked our windows, but yet you give that child a device, you literally are giving access to your child to these predators. Possession of multiple hotel keys, multiple cell phones. We have tattoos of dollar signs, crowns, monikers, profanity. And I'm going to advance just so that we can see. Okay, so I will have to go back to that slide. But just to give you some visual depictions, these actually are tattoos that were with permission of the individuals that we were able to use. So again, please, recognize that this is a form of branding. Just to give a shout out to a very dear colleague and friend of mine, Jessica Lamb. She is a lived experience expert. She also is the founder and CEO of Atlanta Redemption, Inc., where they are transforming these tattoos, self-inflicted mutilation marks, IV drug marks, and transforming them into something that is completely different. So every day that individual no longer has to see that branding or that mark on his or her body. Oops, why did this advance? I don't know what happened. All right, we're going back. All right. Okay, I don't know why it advanced, but here we are. Lying about their age, lack of knowledge of where they are. Sometimes they don't know the day, they don't know what month they're in. Answers appear to be scripted or rehearsed. They're not allowed to speak for him or herself. There is someone who is controlling them, a very domineering companion, again, can be male or female. They are closely monitored, and sometimes that can actually be through a device. And so I will speak to that in a little bit. Poor living conditions, or they are reporting living with their employer. Individual has no control over their finances. I had a lived experience expert share that her vehicle was specifically smashed up by her trafficker so that she no longer had a mode of transportation. And so again, it was another way of having that complete control that she was reliant on that trafficker. Owes money to a person that he or she is fearful of. So we're going to go through those tattoos. Okay, so know the signs. So these are ways that they are going to present clinically. We can have head trauma. very, very big. Seizure activity. We can have those who are presenting with diverse fractures, mandibular, which is to the jaw, orbital to the eyes, facial. We can have them, and they may report that it is after a fall, but yet in the meantime, there is no indication on their hands or arms that they actually had any way of bracing themselves. There are bruising patterns that are inconsistent with the history. The bruising patterns can actually be at different stages. There is, poor hygiene, including dental. They're coming in as domestic violence, IPV, which is intimate partner violence. We need to understand that there is psychological manipulation. It is not the chains and ropes and being physically bound or being abducted at Walmart or, the white van. This right here, this is the white van, this device. So we need to see, oops, sorry about that. I don't know what happened there. Okay. We need to see that they could very well be a boyfriend, a spouse who is the trafficker. And so they may be coming in as domestic violence and intimate partner violence individuals. Oral abscesses, petechiae, which are red marks to the oral pharynx or to the back of the throat. TMJ, which is temporal mandibular joint syndrome. This could be from forced oral sex. They can have GI bleeds, stress ulcers. They can be coming in with dehydration, malnutrition, deficiencies in vitamins, addiction or eating disorders. Please understand that an addiction, that substance use disorder, that could be the vulnerability that made this individual fall prey to a trafficker. Traffickers are recruiting out of methadone clinics. They are recruiting out of Alcoholics Anonymous, Narcotics Anonymous. And so here they come along saying, listen, here's your fix. I'm going to take care of you. I'm going to give you a warm meal, a place to stay. And then eventually what happens is they use that substance to manipulate and control them and say, you go do X, Y, and Z today, and then I'll give you your fix. Or perhaps, or it could actually be that comfort seeking measure that they are using to have this altered sense of reality, this altered level of consciousness, because they just cannot take another minute in the life. Cyclical vomiting or, presenting with these complaints that there is no physiological reason for, no pathological reason for. So those somatic complaints, again, chronic headache, chronic bellyache, abscesses or wounds in need of IND, which is incision and drainage, bite marks, burn marks. Are we recognizing a human bite mark versus from an animal, from a dog, say, for instance? There is profound anxiety or claustrophobia with CAT scan or MRIs. Please understand that the heinous acts that are being conducted against these individuals, the trauma that they are enduring, it is equivalent to that of war veterans. So they are coming in, again, not only with physical acute concerns, chronic healthcare concerns, but they are coming in with mental healthcare concerns. Again, it can be that near overdose. It can be suicidality. It can be depression, bipolar. Are we seeing these individuals, or are we just diagnostically overshadowing, as I had mentioned before? Signs of physical abuse. Again, the findings are inconsistent with the history. Vaginal or anal tears, foreign bodies that are in the vaginal vault, anal vault, ectopic pregnancies, multiple pregnancies, pelvic inflammatory disease, that's what PID is, sexually transmitted infections, UTIs, which is urinary tract infection. Again, struggling with addiction. Are we seeing those newborns that are being born with neonatal abstinence syndrome? Are we just stereotyping moms saying, well, she's just a user, like why couldn't she stop? Or are we taking the time to really explore what is happening? Breast cancer, cervical cancer, HPV, which is human papillomavirus, plastic surgery could be forced, liposuction, organ harvesting. Are we recognizing that 10% of organs that are used in transplant individuals, patients, actually are obtained from organ trafficking? Traumatic dismemberment of digits or limbs, and that can be specifically labor trafficking. Now, why am I going into this kind of granular detail? Because there are chart audits. Are we seeing the multitude of ICD-10 codes, diagnoses, and are we correlating that this could potentially be a victim of human trafficking? And when we look at ICD-10 codes, which is the International Classification of Diseases, we are up to the 10th revision at this point. There specifically are those for human trafficking. I will tell you, and again, I know that you have access to these PowerPoints as a PDF, so certainly you can reference these. But there was a study conducted that was looking at the use and frequency of use of these specific ICD-10 codes that relate back to trafficking. There is a QR code. Please feel free to scan it that you can get the actual study that was conducted and its findings. But there were, I believe, 48, yes, U.S. healthcare organizations that provided their ICD-10 codes. There were approximately 70 million codes that were looked at. And the inclusion criteria were, or I should say, those that were considered positive or that they noted for human trafficking was at least one or more. Please note that out of the approximately 70 million, only 298, I think that's what it says, my glasses aren't on, I believe it's 298, were actually noted. So, you know, what is happening there? Granted, it could be that perhaps these healthcare professionals chose not to use them because their traffickers actually may be the policy holder and will be gaining access to these individuals' healthcare records. But my guess is most of them were not identified. So, you know, when we look at the number that reported being seen by a healthcare professional, we're looking at approximately 70 million ICD-10 codes from 48 healthcare organizations across the country, and only 298 were noted. That is a significant failure. So again, why is this information relevant? We as healthcare professionals have access to this population when they are coming in with their healthcare needs. We also have medical coders, medical billers. I will tell you that they are not required to take this training. And so now they have these charts that they are going through, that they are coding, submitting for reimbursement through the health insurance companies. Again, another failure, because that's a whole nother set of eyes that can be looking specifically for human trafficking. So when we look at health insurance and human trafficking, again, we need to understand that money is usually out the door before the fraud can even be identified to show it has occurred. We need to follow the money. All of you that are working in this space as fraud analysts, anti-fraud, anti-money laundering, and I'm sorry for not really knowing the terminology. Again, this is not my niche, and I don't want to dictate, but what I'm doing with this is sharing my knowledge of the intersection of human trafficking with healthcare, and putting it really in all of your laps to say, okay, this is what we could do on our end. Follow that money. So just some statistics, and I'm sure that some of you are aware, the amount of billions of dollars that is lost. Healthcare fraud is estimated at 3.1 billion in false and fraudulent claims in 2020. Medicare fraud is estimated to cost about 60 billion every year. So we know that the fraud is happening, but how are we going to identify it, that it is with human trafficking and those traffickers that are exploiting the insurance company? So data analytics, help chase suspicious transactions, abnormal patterns in billing. You know, we have AI. We know that exploiters are using it for their own purposes, but we can use it for good to identify those outliers and those errors, those inconsistencies, right? Or those abnormalities. If fraud continues unchecked, at the end of the day, it's ultimately going to cost us as taxpayers, as employees who contribute to plans. So with increased contributions, catastrophic impact on the government. One example is Medicare for health coverage once retired. So again, how are we going to spot this? Let's go through our charts, chart audits. ICD-10 codes, are they being used? Please identify those that are being used. And again, you know, you have the PDF. Are other ICD-10 codes being used? And that's why I got into some of the granularity with those clinical presentations, signs and symptoms, because we can start to see this pattern and say, okay, again, these chief complaints came in. This is the diagnosis. Did anyone say, hey, this could be a victim, that this individual may be a victim of human trafficking? We have upcoding, where the providers are substituting bill codes that they are, say, for instance, they saw this individual for 15 minutes, but yet they're billing for 60 minutes. There are codes that are used for a panel of tests. Are they breaking them up, again, to have more of that reimbursement that they're getting paid? Again, in the ED, packing premiums is another way. So some of this is just generic. Phantom billing for items that they did not provide, or services that they did not provide, double billing, unbundling, and that's what I was referring to with the panel of tests, that they're, you know, billing them separately. In the meantime, there is one bundle for them. Bogus marketing, you know, we have those that are trying to sell healthcare insurance. In the meantime, it's just this criminal activity. Identity theft, identity swapping. And again, I'm sure that you know, are already privy to this. Fraud involving prescriptions, forgery, diversion, their doctor shopping, you know, just making sure that they are able to gain access to that prescription. So are we seeing one particular med constantly being prescribed? Fertility prescriptions, we have, again, human trafficking as that umbrella term, but there is forced surrogacy. Are we recognizing the constant use, say, for instance, under one policy or under a number of policies by one person for Pergonal, for Lupron? You know, there are so many, Pregnil, there are a lot of different ones that we can specifically seek out to see if that is happening. So a case study, what I'm going to do, I'm going to ask Kevin to jump back on, if he will, to sort of provide the how this inquiry started. And I'm going to share my screen because this is something that's animated.
Yeah, so the inquiry, and so my specialty is where technology touches human behavior, especially criminal behavior. And when you start understanding the data more and what's out there and what questions or queries you can ask of it. And we have a good friend, Duncan, who is extremely good at working through massive amounts of data. One of the things, Fran, are you talking about the labor trafficking for the benefits fraud?
The benefits fraud, yeah, that was in the state.
So I'd asked Duncan to look through pretty massive amounts of data to see if he could identify benefits fraud, because we know that this is going on. There are indicators, and it is costing the states millions of dollars per year just dealing with that fraud, and that a subset of this fraud is tied to human trafficking, both labor and sex. Is that enough, Fran?
Yes, thank you.
Also,
okay,
I wanted to point out in the Q&A, if you can see that, there's some pretty good questions in there when you can hit those.
I did. I just actually had the opportunity to go through them now. So I guess before I share my screen, let me touch on some of them. One of the questions, are they more likely to be seen in an urgent care or free clinic instead of an emergency room? So I will thank you first and foremost for that question. Great question. They are being seen in the ERs, okay? Particularly those that are rural in nature. Traffickers now are starting to recognize that some of those meccas, and I put that in air quotes, I use air quotes a lot, they are starting to get more education on identification of these individuals. So they are sort of steering away from the EDs, and they are bringing them to these pop-up clinics, these first meds, or, you know, they're termed a doc in a box or something along those lines. But please understand that it can be seen anywhere. Mother, baby, it can be seen in pediatrics. It can be seen in outpatient, in PT, in dental clinics. These individuals are coming in for diverse needs. So great question. Curious why you identified breast cancer specifically as a potential sign of trafficking. Great question. Thank you so much for that. We are understanding that individuals who have been exposed to adverse childhood experiences, or ACEs is the acronym, that they are manifesting physical ailments along their lifespan. And women who were sexually assaulted, and please understand those that are involved in sex trafficking, and I don't want to say involved, those that are coerced and forced and manipulated into sex trafficking, they are not consenting. Every single commercial sex act is a rape. It is a non-consensual sexual encounter. And so through their lifespan, they are presenting with breast cancer, cervical cancer, early heart attacks, early strokes. And so again, are we identifying these individuals? Are we taking the time to say, what has happened? Were there any sexual assaults? Were there any encounters that were traumatic along these lines? Of course, we want to speak using a trauma-informed lens and approach, but I'm throwing it out there to all of you that you can understand where we are digging and why. When the ICD coding is questionable, who should be notified? Who can be trusted? So, Betsy, that's a great question. Thank you so much for being here. I miss you. So, we need to see first and foremost, who is the policy holder, who is gaining access to the EMR, to the healthcare records. We may need to put this person as a Jane Doe or John Doe or something that we are no longer being able to identify and link that person to that medical record. But again, it all comes to early identification. So I hope that answers your question. Who can be trusted? Please understand that, yes, we have these criminals who are perpetrating these heinous crimes, But please understand that we also have healthcare professionals who are in on these rings. They are getting a kickback. They are working with these networks, that they are seeing patients. Telehealth is a whole nother animal, so to speak. And just before this podcast started, we were actually speaking, Kevin and Erin and I don't know if you're aware, but Amazon offers medical care. They have telehealth. They have pharmacy services. And it's a matter of putting in your chief complaints is what we use in the healthcare industry. What are they presenting with? Their history of present illness. And so there is a nurse practitioner, a physician's assistant, or other type of primary care provider that's going through these responses and literally are prescribing medications. Is there a frequency of sexually transmitted infections where there is an excessive amount of doxycycline that is being written, or antifungals, or something along those lines? So again, just sort of planting seeds for all of you of how you can sort of navigate this to identify. A lot of types of fraud listed are general issues with the medical industry in general, such as upcoding. How can someone who does not have direct patient interaction identify the differences between general fraud and fraud related to human trafficking? Great question. And I think once, and again, this is not my sector per se, but once that chart, if you will, is flagged, then you could start to dissect it and start to see where the fraud is occurring, what type of fraud is occurring. Is it on the behalf of the provider, the healthcare professional, or is it that the healthcare policy holder is manipulating the system? So that's something that you can dive into with your background and how to navigate that.
Francine,
I'm just going to jump back in. Go ahead.
Can I address that one too as well?
Yeah.
So I love this question, Rachel, because it sounds like you're coming from, again, the FinCrime investigator compliance perspective on that one. So I would just throw out if you're an investigator and you have access to these types of records in your investigations or in your firm, I would look up for the business accounts. Is this a new business that you're seeing? And if so, what is their industry? Is it healthcare? Is it claimed healthcare? Is it mostly cash coming in? It's supposed to be transfers. There's supposed to be ETFs, supposed to be ACHs. There's supposed to be type of payments from insurance companies coming in. There's not. And it's just weird, just cash in general. So things like that would be, again, against the KYC, against the Know Your Customer. If you see those things in the FIs or even in fintechs and in the accounts, that's definitely a red flag to say, wait, you're in the medical field or supposed to be in the medical field, and you're not really showing that in these transactions. So we can talk more about that later on another webinar, actually. But that was a really good one to talk about as far as what FIs can see when they're looking at these transactions. I just want to throw that in there. Thank you, Fran.
Yes, thank you, Erin. And also that actually reminded me of workers' comp. What are we seeing with workers' comp? Are they contributing? Are the LLCs numerous and then dissolving? We have these individuals who are being labor trafficked that they're saying, yeah, they have insurance, but they actually don't. So workers' comp is another avenue to explore. And again, I don't know the verbiage, and I'm sorry that I'm not fully versed on how to speak your language, but hopefully that's something that will also help you. Okay, so I'm going to share my screen. And I'm going to share my entire screen, and I'm going to go here. And I'm putting this into PowerPoint presentation mode because it is animated. So the case study. So as Kevin was mentioning, Duncan Edwards with SpyCloud, he has access to infected machines. And so this query was made using state health insurance domain from infected machines. It's a form of data intelligence. It's chasing a paper trail like in BEC, which is a business email chain. No checks were received, so it wasn't monetary compensation that they were getting, but rather policies to see healthcare professionals in that state that, again, taxpayers are paying for. So this was the way that he did it and how he selected it. Again, this is not really my space, but these are the methods and algorithm, so to speak, that he used. And so he logged in, and there was an outlier noted where there were 39 policies from this one particular login ID. So he logged into the subdomain, and this is for the identification purposes that some of these are blocked out so you cannot see. Username and password consistently were Asian in nature. These perpetrators will tend to reuse the password with minimal to no manipulation. Maybe they're capitalizing one letter, but it's lowercase in the next password and account. The IP addresses were all identical. So there were multiple policies for individuals to obtain the services being rendered, again, being seen in the emergency department, inpatient services, mental health, substance abuse, maternity services, using them for prescriptions, medical supplies and equipment, gloves, syringes, are they working in meth labs, needles, gauze, etc. And so just to speak a little bit on labor trafficking, we're just at about 1:20 Eastern time. So I'm just going to quickly touch on this. Red flag, I'm assuming that everyone can still see my screen. Red flags to raise suspicion or indicate fraud, insufficient or no unemployment insurance payments, underreported payroll for workers' comp insurance, which is premium fraud, insurance sale or deduction. The labor broker owns or controls multiple LLCs. Again, some are developed and then dissolved. Labor broker pays workers cash and deducts insurance costs. The LLCs have minimum general liability and workers' compensation insurance. Say, for instance, there's only one office worker. Workers are told that they are independent contractors and must have insurance. Again, bogus claims. And just to touch on something else, healthcare and supply chain and labor trafficking. Healthcare systems rely on global supply chains to source medical supplies, equipment, and pharmaceuticals. So just taking it to another branch of healthcare, again, just planting seeds for all of you to grow and to explore. They often span multiple countries and industries, several of which are vulnerable to forced labor and other forms of trafficking. Additionally, labor exploitation, which can include outsourced cleaning. So this is within the facilities themselves, the healthcare facilities, catering, construction services, environmental services poses a significant ethical concern. Addressing these issues is both a moral and ethical obligation. Protecting and promoting human dignity is at the core of healthcare. Here's another QR code for you that you can find this resource, Advancing Healthcare Through Supply Chain Excellence, AHRMM, which is the Association for Healthcare Resource and Materials Management of the American Hospital Association, is the leading membership group for healthcare supply chain professionals. So again, how are we looking to mitigate human trafficking risks within healthcare supply chain? So here is another QR code. I'm like QR code happy. So again, another resource for you that you can scan and gain access to that. And I believe that is it. I'm going to stop sharing. I'm going to try and find this again. And here I am. And here you are. And thank you so much. And just opening, what's that?
I said, and you were back.
I'm back. Here I am. So thank you so much. I see that there are other questions. Or yeah, Kevin, please, if you feel free to add anything?
No, I just, when you get into the human trafficking complexities, and you mentioned supply chain, if we kind of think of just all the steps of our life that are like that, because when I think of healthcare, I don't really think of the financial aspects of it. Yet the people in finance and investigations and fraud detection and all of that, they are really kind of tied in as a central hub. But if they don't really understand the mechanisms of what you're doing, what you're looking at, and the depth of the healthcare, and actually all of those other connecting points, it's going to be harder for people to really identify the red flags that pop up. So even if you don't work in this space, it's really good to have a background understanding and knowledge of that. We've got another webinar coming up next month that's going to hit on AI and other things, which is also going to have a connection with healthcare and finance and everything else. But I did want to point out that Aaron had mentioned a teller leading to the recovery of a victim. There are also, there are just many stories out there. One of those that comes to mind, I know we have Texas people in here, that there was a pest control person who went in and treated a home and identified some things that just weren't right, didn't look right, didn't seem right, reported that to law enforcement, and ended up unraveling a pretty big human trafficking ring there. So you're looking at bank tellers, pest control, anybody in healthcare, police officers, it's everywhere.
Kevin, also, just living, we're humans. Last January, you were on our January AHT webinar series with Joe Scaramucci.
Right.
And one of our attendees was asking questions based on what you were saying and saying, what if I see this as my neighbor? What if I see certain things? And you were talking about what can happen in labor trafficking. Turns out during that webinar, you and Joe gave her such good advice that she ended up calling local police. They came out, and because of what she was able to learn from you, what she was able to give to the police, she realized and she found out that was a labor trafficking organization ring that was going on next door to her own home. So this happens everywhere because you were able to get out that really good information. I'd like for us to hit a couple questions. Mind if I do that here?
Go ahead.
Let's do that. So there's a really good one here about what are the transaction differences between a trafficking victim and someone who is working for themselves? Do you want to hit that one, or I can as well?
No, go ahead.
Okay. So when it comes from an FI perspective, the differences between a trafficking victim and someone who's working for themselves, if you see it inside of a financial institution, is if they're working for themselves, they would have to pay other bills, correct? You don't have anybody else controlling your account. You don't have anybody else controlling your card or anything like that. You would be working for yourself, and you'd have a rent, maybe a mortgage, who knows? You'd have grocery bills. You have, going out eating. You have all the general things that you have that a human would have. Someone who's inside an organization that's being used inside that organization, they have someone who's controlling that card, controlling the account. You have other IP addresses. You mentioned IP. I'm so glad you did that because that's the lifeblood of our fin crime compliance. You see multiple IP addresses logging into the mobile banking, maybe not touching anything, maybe not making transactions. You will see multiple IP addresses going, or the same IP address that's not even located anywhere near or with that account's the KYC of that account holder. That's a red flag as well. So those are the biggest things that I saw when I was in an FI doing these investigations. There's another one here saying, and this is for you, Fran, do first responders for healthcare professionals identify human trafficking where they may see more context environment where victims may be located?
Great question. And so, when we look at healthcare professionals, that also includes paramedics, EMTs, but it's all first responders, members of service of law enforcement. Sometimes if it is a call placed into 911, they're the first ones on the scene. As Nurses United Against Human Trafficking, we actually have developed a very comprehensive educational program that educates healthcare professionals in particular, and we have case studies, one of which is a 911 call placed for a mom who finds her infant unresponsive in the bed. So the paramedics come in, law enforcement members of service come in. Here they're thinking that this is like a SIDS or SUID, that sudden unexpected infant death syndrome. As the case study unfolds, we find that there are other people who are living in the home, other children. The baby was born prematurely with neonatal abstinence syndrome. Mom had a history of substance use disorder. So yes, absolutely. There are environmental clues. So it's not just healthcare professionals that are working in facilities per se, but those that are first responders. There absolutely are environmental clues. And thank you so much for recognizing that and asking that question. I hope that provided the answer you were seeking.
That was a good one. Yeah, there's another one here. Do most victims have insurance, or are they usually self-pay?
Okay, so some are coming in with no insurance. Some are coming in, again, with a policy by that trafficker. Some it's fraudulent, that there is that changing of name, changing of identity. So again, just planting those seeds, throwing that information out there to all of you that explore these avenues, and just providing those clues for you to locate.
That's a really good one. Thank you. Last one, unfortunately, we only have a few more minutes. This one asks, you did mention that there are healthcare professionals that are in on this, medical professionals that are in on these rings. And
Yes.
So we have one, are they not using the codes because they might not be reimbursed for the medical services? Sick to think medical professionals overlooking human trafficking because they might not get paid.
Yes. So some of them are on the take, if you will, that they are being used for their medical expertise, but they are not necessarily being compensated through health insurance, but by the traffickers and exploiters themselves. So again, a little bit more difficult to trace. However, following the money, looking at accounts, I'm sorry, it looks like something just happened with my computer. Sorry. Oh,
You're still there.
you
Don't
still
worry.
see me? I'm sorry, my screen.
We still see
Okay,
you, so it's all
sorry.
good.
I love it. I love technology when it works. So some of them are actually not even submitting records, and there have certainly been cases of that that are very underhanded house calls. Either they are going to, say, for instance, a brothel or wherever these people are being housed, or they are actually bringing the victim to this provider. And again, they are receiving these services undetected. But in the meantime, that healthcare professional could very well have a service line or a facility or clinic that they are running, but they are not reporting these. So it's a matter of following the money. And again, just planting those seeds for all of you to look for and investigate.
Awesome. Thank you guys so much. Due to time, we have to wrap it up. This is our November 2025 AHT Spotlight series for our community. Thank you to Kevin for bringing you to us, Fran. Really appreciate it. Thank you, Kevin, for hosting again our monthly one. December 16th, you mentioned it. December 16th is our end of year, end of 2025. We're going to be talking about AI images and generators in this industry and how they affect and how we can track that. John Pizzoro, I hope I pronounced his last name correctly, is going to be your guest for December. Also in January, yes, we're all talking about 2026 already. I can't believe that. January, we decided to do a second year now. 2025 was our first, just to see if we can do more for our community to educate about anti-human trafficking or educate about human trafficking and anti-human trafficking investigations. And it was a wild success as far as us understanding our community to know that you want more of this. So you want it, we're doing it again in 2026. January 6, 2026 will be the CEO of Polaris, Megan Lundstrom. She will be welcoming and giving our keynote for the anti-human trafficking series. Every Tuesday in January will be a webinar from ACFCS. The first one's free to the community. You can go ahead and register once it goes. Our website will go live, I believe, this week or next, and you can be able to register for 7 different webinars. Now, January 13, 20, and 27 will be 2 a day. Oh, sorry, not 2 a day, 2 every Tuesday. And Kevin will be on that one as well during the month, talking about his human trafficking response unit model and what it takes to create another model, maybe in your environment. However, they are for members. So if you want to watch any of these other 6, go ahead and get your membership. And maybe you can also get your certificate as well, the detecting and understanding human trafficking. And if you bundle those 2 together starting December 1st, you will get 10% off. But thank you again so very much to Kevin and Fran. I love having you, Fran. I learned so much, and we're not have heard the last from you, that's for sure. Thank you for being a part of this community, and we'll see everybody here December 16th. Thank you.
Absolutely. Thank you.